Hello, my name is Alexander Limkakeng. I'm from Duke University Emergency Medicine, and I'm going to be talking today about interpreting troponin, which is a common problem for emergency physicians. Some disclosures: I have had research support from the following entities, and of note, these top two are producers of troponin assays. However, I have no personal proprietary financial interests to disclose. So to review, cardiovascular disease is the #1 killer of Americans, and it drives up to 6 million people a year to the emergency department with the symptoms of chest pain. Annually, there are almost 1 million patients diagnosed with an acute myocardial infarction a year, indicating that this is a significant disease burden for Americans. And troponin plays an important role in our assessment of these patients. So I'm going to talk a bit on two general areas. Why are we interpreting troponin? And you'll see why that is even a question. And then I'm going to discuss in the second half of my talk on how do we actually do this? How do we interpret troponin, and how should we, given some of the recent advances in troponin assays? So first, the question I'll address: why are we interpreting troponins, in quotes? It's interesting that in one recent editorial, the troponin assay has been described as a mild-mannered laboratory test which has metamorphosed Marvel Comics fashion to a rampaging diagnostic monster, as you can see illustrated in my picture here. So how is it that this test that we use every day has become such a diagnostic dilemma and such a concern for clinicians worldwide? To recall, in the first hours of the emergency department evaluation for acute coronary syndrome, you have certain tools in your toolbox. You have the history, the physical exam, electrocardiogram, and chest x-ray. And of course, we're all familiar at this point that cardiac biomarkers are an important tool that we have in the initial phases of emergency department evaluation to help us triage patients to levels of risk. And in fact, troponin has long been considered the gold standard amongst cardiac biomarkers for exactly this function. And that's for good reason. It's because cardiac biomarkers have several advantages over some of these other tools that I just mentioned. They're non-invasive, they're repeatable, they're entirely quantitative and reproducible, they're relatively inexpensive compared to many interventions that we do. They're widely available 24 hours, 7 days a week, which is important for emergency department care. And they don't particularly require specialized personnel or technology. These are things that are available at almost every emergency department in the United States. Furthermore, what has been called the troponin hypothesis has largely been proved. And the troponin hypothesis, to be stated, would be that troponin tests can identify a subset of patients with acute coronary syndrome for whom particular treatments would benefit. So this goes beyond just risk stratification in identifying patients at risk for bad outcomes. An example of this was the Plato trial, in which troponin levels identified not only those patients who had worse outcomes overall, but those patients who benefited from invasive management, and furthermore, those who might benefit from a particular drug, ticagrelor. So it raises the question, though, since this is such a part of our everyday practice, how is it that we, or why is it that we would interpret this test? We're very familiar with diagnostic imaging, for example. On the left of the screen, you'll see an image of a coronary artery CT scan, and we're very used to talking about interpreting images and those sorts of tests. However, as I just mentioned, a troponin test gives us a quantitative result, which would raise the question of why is it that we need to interpret this number when it's clearly understandable and quantitative. You might argue there's not much to argue about the result. So to dig deeper into this question, I'm going to talk about two elements of why we do this. The first is our target. In other words, what are we using the tool for? And second, I'm going to talk about the tool itself. So I'm going to talk about troponin assays a little more in depth. In talking about our target, it's important to remember why and how it is that we are ordering a troponin test, and to keep our focus on our target. troponin tests have been approved for the diagnosis and risk stratification of acute myocardial infarction. And let's remind ourselves exactly what that is. A myocardial infarction is defined by a typical rise above the 99th percentile and fall of cardiac biomarkers. So, in addition, this definition includes the need for ischemic symptoms, ECG changes, imaging evidence, and there's subcategories for special situations such as patients with sudden death or who've had interventions, and which I'll talk about in a short bit. But as you can see, one of the difficulties in establishing a diagnosis of myocardial infarction then is symptoms. So from the recent CDC data from the MHSc, we were able to look at, through 2009 and 2010, what are the symptoms, presenting symptoms of patients for which a troponin test was ordered. And on the right here, you can see that a little over half of those patients who had a troponin test ordered had what we would consider to be pretty typical anginal symptoms. You might even include abdominal pain as one of those, so that's being a bit generous. But a little over half of patients have symptoms that would be reasonably considered typical angina symptoms and clearly associated with the possibility, at least, of acute coronary syndrome. The problem exists with the other half of patients for whom troponin is ordered. And you can see that there's a wide variety of symptoms and types of symptoms in which this test is currently being ordered. And you can see that that would also lead to some confusion over exactly what is the role of troponin testing in these patients. So to show you diagrammatically where myocardial infarction exists in terms of troponin test results, our target is this. So we're aiming to diagnose myocardial infarction in patients who have clinical evidence of ischemia and rise and fall of troponins. So on the one hand, we have the difficulty of the wide variety of symptoms that could lead to myocardial infarction. On the other side, we have the problem of there are many entities which are not myocardial infarction that can cause myocardial injury and give you an elevated or detectable troponin level. So you can see that, for example, besides in the penumbra of what we consider to be true myocardial infarctions, there's a number of entities that can cause what are best described as myocardial injury, in which there's cell death marked by detectable troponin levels, and these can be caused by things such as cardiac procedures, even non-cardiac procedures, arrhythmias, heart failure, renal failure, and a variety of other conditions, as you'll see. So diagrammatically, again, you can see that elevated troponin or detectable troponin levels even can be broadly categorized into one of two categories: ischemic and non-ischemic. In the ischemic category, there's what we all recognize as a classic acute coronary syndrome here, with a patient presenting with an acute clot within a coronary artery. However, there are other entities that are not acute coronary syndrome that can lead to a true ischemic myocardial infarction, meaning hypoxia, and those include an increased oxygen demand for a variety of reasons with a limited flow, spasm, procedures, drugs. And then on the other side of things, there are non-coronary events that can also lead to a true myocardial infarction, which is to say hypoxia. And then on the flip side of elevated troponins, there are a wide array of conditions that lead to myocardial damage that have nothing to do, or at least not necessarily have anything to do, with coronary artery disease. And these would be properly termed myocardial injury. And these are all things that anybody working in the emergency department is very familiar with and has seen. So now that we understand the problems in terms of the overlap of our target with various other diseases, as well as the difficulty in determining the correct population symptom-wise in order to order our test, let's study a little bit more about our tool, the troponin assay itself. And this is an important area because this is an area in which the literature and our technology is rapidly evolving, which has perhaps raised some of the concern elucidated in a prior slide. So just to review, cardiac troponin is a cardiac version of a muscle protein, meaning when we say troponin, we really should be talking about cardiac troponin. We all say troponin for short, but the assay tests a specific version of a muscle protein, which is present in all of our muscles. Therefore, because it's specific to the cardiac version of this muscle protein, it's specific to myocardial injury. And typically, when there is injury of some sort to your myocardium, these levels will rise and be detectable within 6 to 8 hours and remain elevated for 5 to 10 days. As I alluded to, however, there are a number of conditions and disease states that can lead to myocardial injury and therefore troponin elevation. At the cellular level, there are a number of different entities and mechanisms by which troponin is released into the blood, and in some cases we're still not clear which disease states lead to which disease states are associated with troponin elevation by which mechanism. For example, there is simply the turnover of myocardial cells, as in any other part of the body. There's programmed cell death, apoptosis. There are myocyte necrosis, which is the classic way in which we think of with ischemia. But there's also release of degradation products and cytosolic pools. So if this were to represent a myocardial cell, there's troponin within the cell wall structurally, but also some of it floats around here in the cytosol. And these can be released in particular in states where there's increased cellular wall permeability. And so you can see that it can be difficult to predict, even based on cellular mechanisms, which disease entities are going to be associated with troponin elevations. So in talking about our tool and in the recent and evolving literature, I often like to hark back to the initial reception we gave to our contemporary troponin assays. And very much it was like this picture here in which you see our reception of a mobile cell phone. It seemed to be great. It seemed to be revolutionary that we could actually take a phone and move it around. However, the current and most recent generation of troponin assays, which are properly termed high-sensitivity troponin assays, are going to make our old assays look very much outdated, much like the phone in this picture. So the term high-sensitivity troponin raises the question, what makes it high sensitivity? A better way to describe it would be that these assays have a lower detection limit, which means that also they have a higher precision at lower troponin concentrations. To give you an example, at my institution, we use a cardiac troponin T assay where the current cutoff is cited as 100 nanograms per liter, or that's the equivalent of our units. Whereas most high sensitivity troponin assays being proposed have a cutoff of 14 nanograms per liter. And here's the promise. The idea is that by having a lower detection limit with higher precision at these lower concentrations, we'll be able to take patients who have acute myocardial infarction, and whereas in the past we would be only detecting folks in this range, by lowering that detection limit, these folks here who have myocardial infarction but were below our prior detection limit will be able to be detected, and with great accuracy. And indeed, the literature that has emerged from high-sensitivity troponin research has borne this out. There are a number of studies indicating high sensitivity for acute myocardial infarction in patients presenting to the emergency department. You can see that the area under curve for a variety of troponin assay manufacturers and particular assays is indeed extremely high. So much so, and there's been enough literature at this point that multiple meta-analyses have been published documenting the ability of high sensitivity troponin assays to live out to their promise of having high sensitivity for acute myocardial infarction. However, there are problems that are being raised by this new technology and these new assays, which again raise the question of why we need to interpret the results. And included among these are specificity and, related to that, cutoffs. So as I alluded to earlier, here is where we stood when we talked only about the sensitivity of troponin assays. The promise was that we'd be able to detect more patients who had acute myocardial infarction with low-lying levels of initial low-lying levels of troponin. However, this comes at a cost to specificity, just like many other tests. And indeed, you can see that if we were to overlap a curve of patients without myocardial infarction, that there is indeed a number of patients who also have troponin levels that are in this range of gained detection, meaning below 100 nanograms per liter, for an example. So this red range here indicates the problem of overlap and patients for whom overdiagnosis or false positives may occur, and therefore these assays can be associated with low specificity. And indeed, in these same studies I cited highlighting the high sensitivity of these assays, the documented specificities are not what we would like them to be. Another problem that is evident with very low detection limits is that we're becoming more aware that the cutoff of normal or 99th percentile may differ not only on assay but also for age. So patients, for example, over the age of 75, the 99th percentile ranges can be as high as 92 to 150 nanograms per liter, which would raise the specter of different cutoffs depending on your age. And likewise, the 99th percentile in males can be up to 2.4 times higher. So as we lower our detection limit, we're seeing problems in the sense of being able to find different cutoffs for different subpopulations, and that can make interpretation that much more difficult. So I've talked at length about why it is that we need to interpret this quantitative test. And now I'm going to move forward with some suggested strategies on how to do this. And there are two principles that I'm going to introduce, which are shortly summarized by more is better and more is worse. To clarify, when I say more is better, I'm referring to serial testing, in other words, using troponin assays and testing them at more than one time point in the emergency department patient's stay. So more testing, more troponin in the sense of serial testing is better. And the other way in which more is worse, conversely, is a higher troponin level, regardless of your underlying clinical state, is almost always associated with a worse outcome. So these are two principles that will help the physician interpret troponin levels. And to clarify just again, when I say serial testing and more testing of troponin is better, I'm not talking about indiscriminate ordering of the troponin test. In fact, I'm arguing for just the opposite by this entire lecture. Interpreting troponin tests includes considering beforehand who would benefit most from this troponin test with the understanding and knowledge of these overlaps with normal populations. So just to emphasize again, when I say more is better, I'm not talking about indiscriminately ordering the test on more patients, but rather serial testing. So there's existing literature, even with our contemporary assays, regarding the issue of single test or one set rule-outs for myocardial infarction using troponin assays. Our work back in 2001 demonstrated that even in the lowest risk pre-test population, there was still a sizable rate of acute coronary syndrome following an initial emergency department presentation, about 5%. An important feature of this population that we studied, however, was that the time from onset was averaged around 4.5 hours. Christian Ham and et al. Looked at a cohort in which the sampling was specifically designed such that there was at least one set over 6 hours from the patient's pain onset. And when you were able to carefully control for that pain onset, he found a very low adverse event rate if that sample was negative. And indeed, there is an ACEP policy and STEMI for practice guideline, which has level B evidence that says that you can exclude acute myocardial infarction, which is not the entire spectrum of acute coronary syndrome, so not unstable angina, but it does state that you can exclude acute myocardial infarction with a marker at 90 minutes, a negative 2-hour delta, and importantly, if there's a single marker at least 8 to 12 hours from the patient's symptom onset. So this is established even with our contemporary assays. One thing to note, and a careful caveat of the policy, is that if the time of symptom onset is unknown, unreliable, or more consistent with pre-infarctional angina, then this time of symptom onset should really be set at the time that the patient presents to your emergency department. So there's a number of patients for whom this policy would functionally not apply. Also, with the new and emerging literature on high sensitivity troponin levels, there is some suggestion that we may be able to use one set to rule out some patients. So in this study, they looked at early presenters with less than 2 hours. Patients with less than 2 hours of symptoms were excluded. So patients who had symptoms for at least 2 hours. And they found that if your initial troponin level was undetectable, meaning even with the high sensitivity troponin, low detection limits, even with that assay, it was still undetectable. It had 100% sensitivity and a very high negative predictive value. And adding in an ECG, the negative predictive value nudges up even higher. However, it's worth noting that only 20% of patients in this very large cohort met this criterion, and therefore it seems likely that we're going to continue to need, for a large number of patients, serial testing. So in conclusion, on the topic of one-set rule-outs, it may be possible for a few selected group of patients, but if you choose to do this, and if you are targeting that, the time of symptom onset and documenting that would probably be key. So I've talked a great deal about serial testing, and indeed one of the new studies out using high sensitivity troponin assays demonstrates high sensitivity and in fact pretty good specificity with very rapid serial testing. This is a study from Tobias Reichland et al., and they used a 1-hour protocol of serial testing and found that at least 60% of their patients could be ruled out with a very high sensitivity and negative predictive value. However, there was still about 23% for whom one of those first samples was not negative or low, and therefore required serial testing and observation even beyond the 1 hour. Another solution beyond simply repeating the test and declaring the assay declaring the test either negative or positive is to do the calculation of the actual value and the difference. So in other words, determining the change from baseline to the second set. These are called deltas. And when they studied this, having a 20% delta increased the specificity up to 92% in the studies that I have mentioned with very high sensitivity results. However, including a delta, a 20% relative delta, reduced the sensitivity of the assay to 56%. These same studies demonstrated an absolute delta, meaning measuring in actual units as opposed to percentages, performed somewhat better with an area under the curve of 0.851 to 0.845. Multiple studies have now been published that demonstrate an absolute delta is helpful for these serial testings with rapid rule-outs, often under 2 or 3 hours, and in emergency department settings. So to conclude, the principle of more troponin is better, more testing is better, in regards to serial testing and delta values is true. And serial testing and delta values clearly have better diagnostic test characteristics, particularly in a broad-based population than single sets for whom you may need to carefully select patients. So now that we've talked about more is better, let's talk about more is worse. When you get a result, you may note we'll be seeing more often that patients will have at least detectable levels of troponin. And it's important to remember, regardless of the clinical context, having a higher troponin level in almost every scenario is associated with worse outcomes. So to get back to more is better, we often think of troponin assays as being a dichotomous test, meaning there is a positive and negative, very similar to a pregnancy test. And in fact, this positive or cutoff that we often refer to in clinical use can have a couple of definitions. One definition of a cutoff would be the 99th percentile. In other words, if you take the entire normal population and take the 99th percentile of that population, that gives you a very low level at which the troponin assay might be considered positive. If you're in the 1 percentile, highest 1 percentile of a normal population, that could be considered positive. The manufacturers, when they develop an assay, try to maximize accuracy, and so they do some broad-based clinical testing to determine exactly at what concentration they're going to declare their cutoff. Meanwhile, many professional societies declare a cutoff should be the lowest value at which the coefficient of variation is 10%. So in other words, the coefficient of variation is merely the standard deviation over the mean, and the lowest concentration at which there is pretty good precision, as measured by this variable, the 10% CV, should be the level at which your assay should be declared cutoff. And so you can see that your cutoff can depend a bit on not only your assay, but also your reference population and your demands on precision. And so, for example, at our institution, the cutoff, as determined by the manufacturer, would be 0.10, and this is in micrograms per liter. The 99th percentile, however, is 0.01, and although it's not listed in the assay's reporting, the 10% CUV would actually be 0.03. So some patients may get a value that is in between these three different cutoffs, which can lead to some confusion about how to interpret them. Therefore, I'd advocate that we not view troponin as a binary or dichotomous test, and simply refer to patients whose assay results are beyond all cutoffs as being elevated as opposed to positive. When we talk about elevations, even with contemporary assays, it's been demonstrated that even having minor elevations of troponin is associated with worse outcomes. In this graph, we see on the left-hand side, or the y-axis, the cumulative proportion free of events. So in other words, being closer to 1 is better for the population. And on the x-axis, we see time. So this is a bit like a survival curve, although we're talking about free of all ACS events. It can be seen that patients with normal, meaning undetectable really, levels of troponin initially had the highest survival, and as we expect, patients with what are termed in this study frank elevation, which would be above even the manufacturer's cutoff, for example, they had the worst proportion of free of events. But even patients who fall in between have outcomes that are in between these two groups, meaning that patients who fail to get to the frank elevation level still should have attention paid to them. And additionally, this is true for patients for whom cardiac diagnoses or cardiac diseases is not their primary concern. So again, on the y-axis, we see survival in terms of percentage, and on the x-axis, you see time. And there are two curves. So this top curve represents patients who had low troponin values, meaning less than 0.04 micrograms per liter. And you can see that even in patients who are critically ill, non-cardiac ICU patients, who weren't presenting with primary cardiac events, having a higher troponin level is associated with worse survival. What about in sepsis and shock? Frequently we see patients with, for example, a pneumonia or other infections, and an elevated or detectable, at least, troponin level. Multiple studies have demonstrated that there's an increased mortality in patients with septic shock or sepsis with an elevated troponin level. And in fact, this is not merely a marker or association with CAD, or that the patients with sepsis and elevated troponin levels are more likely to have CAD. In fact, in many septic states, there's actually increased coronary blood flow. In some of these studies, they were able to do continuous ECG monitoring and transthoracic echocardiography, and that this association was not mediated through acute coronary syndromes or secondary acute coronary syndromes. In other words, they were not associated necessarily with ischemia or infarction, but really through other mechanisms. What about in pulmonary embolism? Beccattini et al. In 2007 produced a meta-analysis of patients with pulmonary embolism who had troponin assays. And what they found, indeed, was that having an elevated troponin was more likely to be associated with right-sided heart failure, and having an elevated troponin was an indicator of increased overall 30-day mortality from 19.7% if you had an elevated troponin versus 3.7% if you didn't have an elevated troponin. And this was true even in the subset of patients who had normal blood pressure on presentation. What about in renal failure? Many times we see patients with end-stage renal disease or who are on dialysis, and the observation is that frequently these patients have an elevated or at least detectable troponin levels. Again, another meta-analysis produced by Kahn et al. Has demonstrated that in aggregate, patients with end-stage renal disease who have higher troponin levels have a higher risk ratio for mortality. Here's a study by Contos et al., and I'll walk you through the slide. On the left-hand side, on the y-axis, you see the overall mortality, so higher is worse. And on the x-axis, we have two groups of patients. First, patients with a frankly elevated troponin and patients with a frankly undetectable or negative troponin. And we can see that within each of these groups, even if having worsening renal function is associated with worse outcomes. So in the black are the patients with worse renal function as noted by a creatinine clearance of less than 30 mLs per minute. This goes up to 60, and then these are the patients with normal renal function. So within the troponin negative group, having worsening renal function, not surprisingly, was associated with worse cardiac outcomes. But compared to their peers in every renal function category, having an elevated troponin was associated with far worse outcomes in every every category of renal function status. So again, even in folks with end-stage renal disease, having an elevated troponin is associated with worse outcome. And again, I could go on, but there are multiple studies in multiple conditions demonstrating that having an elevated troponin is worse for your outcome. Stroke, atrial fibrillation, COPD, and even in a healthy reference population. So that brings us to our conclusion, which I think is best stated in this Journal of American College of Cardiology article. Global risk assessment, rather than any single risk marker, should be the main driver of our therapeutic decision making when it comes to risk stratification of acute coronary syndrome. We need to consider all the factors, including all those things in the toolbox: the history, the physical exam, electrocardiogram, chest x-ray, and perhaps clinician gestalt in interpreting troponin, even though it is a quantitative test. And the recent developments in high sensitivity troponin assays is going to make this job that much more difficult, but is going to require more education and more knowledge on the emergency physician and a better assessment of the patient at the bedside. So I'd like to propose in closing that we change our troponin language a bit, and in so doing perhaps change our thinking. I've demonstrated under tools that we're not talking about cardiac enzymes, although that's a commonly used phrase and it has come into general acceptance. But these are really cardiac markers, and they're structural proteins. And although troponins are cardio-specific in terms of the muscle, we must remember that they are not coronary specific. So every elevation of troponin is not necessarily ischemia or an acute myocardial infarction. And rather than talking about troponin as either negative or positive in a dichotomous way, we should think about using the terms detectable, which is more accurate, or elevated. And again, that doesn't give us a diagnosis necessarily when we say that it's elevated, but merely reflects where it is relative to population norms. So in summary, troponin must be interpreted, and I hope that this lecture has helped you understand how to do that and why we must do that. It's important to know your tool and your target and keep abreast of the evolving literature on this topic. One of the challenges with high sensitivity assays is that frequently high sensitivity also is associated with low specificity. One of the things as emergency physicians we have to keep in mind is that more troponin is worse, meaning higher levels of troponin is always associated with a worse outcome, and we have to take that knowledge and apply it to our patients in an appropriate way. And that despite the promise of early and one-set rule-outs, probably more often we'll be using serial testing and deltas, which give us better diagnostic test characteristics, even though that may actually be able to occur in much shorter time frames. In conclusion, my name is Limkakeng, and I'm from Duke University. Thank you for your time and attention.